All right, well, the numbers are still climbing, but I'm going to go ahead. I just wanted to welcome everyone this afternoon to Pain, Discomfort, and Sensory Changes in Adrenal Leukodystrophy. I'm honored to be facilitating a discussion among Dr. Florian Eichler, rockstar pediatric and adult neurologist from Mass General, and Dr. Brian Wishart, who is just an absolute gem, and he will be joining us later for this very important discussion close to all of the patients. So I'm so grateful to be here. And I will just ask everyone, as usual, this is not intended to be, this is intended to be the start of a discussion and some talking points for you to bring back to your own physician. It's not meant to take the place of your actual direct medical care. And also, if you know already that you have a question that you'd like answered, don't hesitate to put it in the chat in the Q&A. I'll be combing through both to try and make sure that we can answer as many questions as possible. And with that, Dr. Eichler, take it away.
Great, thanks Kathleen, and delighted to be here on what I think is really the heart of ALD Connect, the Patient Learning Academy. And the questions that you patients and families are bringing to these topics. Again, for those of you who don't know me, I'm a neurologist at MGH, and Dr. Brian Wishart is a physiatrist who's been of great assistance to our leukodystrophy clinic. I have no relevant disclosures to this talk. Just to start off and recap what we know briefly about adrenal leukodystrophy. As most of you know, this is a single gene disorder due to mutations in ABCD1. It leads to an increase in very long chain fatty acids as the mutant protein cannot transport very long chain fatty acids into the peroxisome. What has been a mystery for many decades is why, despite these elevations in very long chain fatty acids occurring across the body, only certain parts of the nervous system and the adrenal gland are affected here. And this is really guiding us to a new understanding of the pathomechanism and how disease develops in ALD. So I'm going to focus here on a topic that many patients come to me for, which is pain. And I just want to emphasize that when we speak of pain, we're not talking of only one thing. There are many different causes of pain, and hence the most important task in our clinic is to sort out what the underlying cause of pain is. Is it a neuropathy? Is it due to this peripheral nerve causing dysfunction? Is it due to circulation problems, vascular insufficiency? Is it muscle spasms and spasticity that are causing pain and like discomfort? Or is it a movement disorder such as restless leg syndrome, something that we have over the past year been exploring more, and as we find it to be disrupting sleep and impacting quality of life in many of our patients. So, brief overview of the symptoms that we've been seeing in our leukodystrophy clinic. And just to point out that this is a multidisciplinary clinic with also nurse practitioner Katie Becker, physiatrist Brian Wishart, neuromuscular expert Dr. Sayed Sejadi, all contributing here and helping me sort out the different signs and symptoms we see in adults with adrenal leukodystrophy. As you can see, a large percentage of patients have gait problems, bladder problems, and bowel dysfunction. What's important to note is that both men and women are affected, but in women in particular, we find more complaints of pain and sensory disturbances compared to men. In men, it seems that spasticity and muscle tightness and spastic gait are more prominent. For many decades, the field did not think that women were as affected as men. And this is a really changing landscape as medicine and doctors are becoming more aware of the plight of women. Nevertheless, groups like the one in Amsterdam have led this field in pointing to symptoms in women. In 2014, a group of Mark Engelen demonstrated that women were very similarly affected to men with adrenomyeloneuropathy, albeit at a slightly later age. And he pointed out that the symptoms were very much related to the spinal cord disease of myelopathy, as well as neuropathy symptoms. And you can see that the older you are, the higher the percentage of patients affected among this female cohort. So what is a neuropathy? So neuropathy is related to the peripheral nerve that comes from the spinal cord out into the dorsal root ganglion and travels to muscle and blood vessels, sending motor signals to those structures. And on the other hand, it also brings information back from skin and the periphery on sensation and carries that back to spinal cord and the central nervous system. As such, it is very important to mediating our position sense and our ability to discriminate touch and pain. Among the peripheral nerve, a very important structure is the very smallest nerve fibers that sit in the skin. And over the past few decades, we've learned that these small nerve fibers contribute greatly to tingling sensation, burning pain in the feet, but they can also give rise to a reduced sensitivity to heat or certain types of pain. And so we have been pursuing studies with skin biopsies to understand what is happening to these small nerve fibers. You can see that here on skin biopsy. In normal skin biopsy, the small nerve fibers travel here from the dermis below here into the epidermis and have a normal configuration. In small fiber neuropathy, these small nerve fibers are often absent, showing here that there is something going wrong. When we examine patients beyond their complaint of tingling sensation or pain, we note that their feet are often swollen or discolored. And this has to do with the close proximity of the small nerve fibers to blood vessels. And these nerve fibers are responsible for innervating those small blood vessels and capillaries. And if they don't innervate them well, this leads to a pooling of blood and discoloration, as you see here. This can be very uncomfortable. And a group in Norway measured small fiber neuropathy in patients with ALD, and it was just a small cohort of 11 patients, but even in this small cohort, they found that about half of them had clinical signs of a small fiber neuropathy, and often verified then on skin biopsy, where they examined those small nerve fibers that I just showed you in the prior picture. So our understanding here of the small fibers are evolving, and we understand that beyond what we can measure by nerve conduction, velocity, which represents the large fibers, there are these small structures that are contributing here to pain and discomfort, and it's something that we need to understand if we want to appropriately treat and relieve pain in patients affected by ALD. This can be tricky because beyond the small fibers, there are other parts of the body that can contribute to discomfort in the legs. Prominent among this are circulation problems. So symptoms of venous insufficiency can cause pain and heaviness, discoloration. You all might have seen what varicose veins look like, but they often don't have to be present for vascular insufficiency to be causing discomfort. So as we think about small fiber neuropathies, we need to distinguish this from circulatory problems and understanding that there's an overlap between leg cramps, spasms, pain, and restless leg syndromes. Moving from neuropathy now to myelopathy. So myelopathy here is a disease of the spinal cord. And in ALD, we find vulnerability of the longest nerves in the body, which is the cortical spinal tract that brings information from the motor cortex down through the spinal cord and sends signals to muscle. And on the other hand, the long nerve fibers bringing sensory information back to the nervous system through the dorsal columns, which travel here in the back part of the spinal cord. So both of these long tracts affect gait and balance and bowel and bladder function. Here, an outline of the kinds of symptoms that the spinal cord disease can cause. And just to point out, among these symptoms, prominent spasticity, muscle spasms, and sensory disturbances, all aspects that contribute to pain and leg discomfort. What kinds of signs and postures are we looking for when we examine patients with lower limb spasticity? Sometimes we see that the legs are adducted or brought together and tight and cannot be easily separated. Knees are often flexed, as you see here. Often the heel cords are shortened and feet are inverted. We're often examining how somebody walks and looking for little signs like this. Even something like looking at the big toe and whether it is upgoing or not gives us a sign of whether spinal cord disease is present or not. So why think so much about myelopathy and distinguish it from a neuropathy? Well, it affects the gait and it affects pain differently. If you have a prominent myelopathy and the cortical spinal tract is affected, often your gait is more spastic. And this is shown here where a man affected by AMN has scissoring gait, meaning that his legs being spastic is prone here to gait difficulties because of that. In addition, often sensory information from our joints and from our periphery do not travel well through the dorsal columns, affecting our awareness of the position and the movement of our body. And so you can see how both spasticity, weakness, and balance all come together to affect how not only we walk, but how we navigate the world. We've been trying to study this in more detail together with Masai Nier, where we use a vestibular lab, where we can put patients safely into a harness and have them stand in the lab and examine their balance as we look at how they react to different perturbations and different changes in their visual environment or in the surface on which they stand. And as we move that surface, we see how they adapt and how they react. And you can see that as you change both the surface movement as well as the visual environment, it is very hard for patients to adapt, having both balance problems due to dorsal column and spasticity due to the cortical spinal tract. However, we are gaining more insights into how spasticity is caused, and there is a mouse model of adrenal leukodystrophy that, although it has symptoms very late, it does develop a hind limb clasping very similar to spasticity that we see in patients. And you can see here the mouse that has clasping behavior of its hind limbs. And interestingly, if you deliver a healthy copy of the gene into this mouse that lacks ABCD1, you can correct this hind limb clasping if you deliver the gene with an AAV into certain parts of the brain, such as the basal forebrain. And then these mice develop more healthy extension of their hind limbs. So shifting now from the topic of spasticity to another cause of leg discomfort, namely restless leg syndrome. Clinically, we define restless leg syndrome as the experience of having the urge to move one's legs with an uncomfortable sensation of either crawling, creeping, throbbing, or aching in the legs. And this often comes on in the evening and requires the patients to move in order to find relief. And here a brief video of what this looks like. As I mentioned, this comes on in the evening, often when lying down or sitting, and there is this urge to move in order to relieve the discomfort that patients are experiencing. Now, we did a small study in about 30 patients where we interviewed patients about symptoms of restless leg syndrome. We were lucky to have a world expert here at MGH, John Winkelman, who guided these interviews. And we found that about 40% of adults with ALD had symptoms of restless leg syndrome. This is higher than the normal population, where we see about 5 to 10% of patients experiencing restless leg syndrome. So it is definitely something that is occurring in adults with ALD and requires more attention on our side to identify this and discriminate this from other symptoms. Interestingly, we found that those patients who had restless leg syndrome also had more symptoms of spasticity, hyperreflexia, impaired sensation, and gait difficulties, pointing to the fact that either the myelopathy underlying all of these symptoms was contributing to restless leg syndrome, or inversely, that having sleep difficulties due to RLS causes all of your daily performance in gait and balance and other domains to worsen. So this is really an exciting first step to identify this, because we've clinically found that if we treat patients appropriately, we can improve their sleep, and their daily performance of gait and balance can improve. So in this last section, I will now talk about pain in adrenal leukodystrophy as it involves both peripheral and central nervous system. I talked mostly about the small fibers and the spinal cord symptoms, but also to mention here that thalamic networks and brain networks are contributing to pain and pain perception. We've spent a lot of time on an important structure that mediates between the peripheral nerve and the central nervous system, namely a small structure that sits next to the spinal cord called the dorsal root ganglia. And these dorsal root ganglia act as a hub network of neurons that bring information from the periphery and pass them on to the central nervous system. And looking at mice with adrenal leukodystrophy, we find not only that they have a lot of pathology within the dorsal root ganglia, but these mice also have marked changes in sensation. They have a heightened sensation of pain, and when you use small filaments to poke their hind limbs, they react and withdraw those hind limbs much faster than wild-type mice. Examining this closely, we found that they express a certain kind of neuronal subtype that expresses a lot of piezo2, which is a certain mechanosensitive ion channel that is shown in this graph below. So why is that important? Well, it turns out that if you have more piezo2, you might be more sensitive to touch, more sensitive to pain. And this has actually, over the past year, gained a lot of attention as the Nobel Prize for Physiology and Medicine was given to the person who discovered these piezo channels back in 2010, namely Artem Pataputian. And so we are extremely excited that our research into this is coinciding with this recognition to Pataputian, and we hope that his discovery of piezo2 and the tension that these pathways are now gaining will lead to new interventions and new treatments that will more appropriately address pain in the future. So in our mice, what we did is that knowing that piezo2 was upregulated, we decided to use a channel, piezo2 channel inhibitor. That means a medication that blocks this specific channel, and see if we could restore mechanical sensitivity. And sure enough, you can see that the mouse now doesn't withdraw its hind limb as quickly as before, but we only partially rescue this sensitivity of the hind limbs. Why only partially? Well, we found out that actually a lot of ABCD1, a lot of peroxisomes are not in the neurons of the DRG, but in the cells surrounding those neurons, namely the satellite glial cells. And this has been known since the 1970s, where you see here in a nice electron microscopy slide, a lot of peroxisomes are surrounding the neurons. And in those peroxisomes of the ALD mouse, the ABCD1 is of course missing, leading to high amounts of very long chain fatty acids. And these high amounts of very long chain fatty acids sitting in these satellite glial cells are further contributing to pain and altered sensation in the mice. So what do we think is happening in ALD? We right now in our lab are focusing in large part upon the question whether mechanosensitive channels are altered in adrenoleukodystrophy. What we think is happening is that you have more piezo2 channels in the absence of ABCD1. Surrounding those neurons are satellite glial cells that are full of very long chain fatty acids and GFAP, which is something that causes scarring, all of that contributing to dysfunction of that mechanosensitive channel. Importantly, many years ago, Jim Hamilton and Hugo Moser showed that lipid membranes are altered once very long chain fatty acids accumulate. And we are wondering whether the accumulation of very long chain fatty acids in membranes themselves of neurons are changing the configuration of these piezo channels, making them more open to ions traveling in and therefore increasing the sensation of pain. Beyond pain, these piezo channels are contributing to balance, as I outlined before, but also to bladder problems. And Artem Pataputian always emphasizes that actually part of his discovery is going to contribute to our understanding of how bladder function works. Our sensation of whether our bladder is full or not depends on these piezo channels, and therefore our ability to sense when the bladder is full and needs to be emptied is critically informed by these piezo channels. So in summary, pain in adrenoleukodystrophy is multifactorial. I hope I've shown you that it has many implications, also for balance and for bladder dysfunction. Most of the symptoms are due to myelopathy and neuropathy. These are the compartments of the nervous system that are due to spinal cord disease and peripheral nerve. But beyond that, circulation and functional brain networks contribute. So we have to pay attention to aspects of venous insufficiency. We have to think about movement disorders such as restless leg syndrome. But there is a lot happening in the field, and just the fact that we're discovering mechanosensitive channels that will likely give rise to new drugs, new medications that might selectively target channels that are dysfunctional in ALD is very exciting. And I think that between that and understanding how to inform lifestyle changes and exercise and physical therapy, much progress can be gained. I think the most important part that we do here in clinic, together with Dr. Wishart, Catherine Becker, and Dr. Sejadi, is understanding the underlying cause of pain. You cannot have a rational treatment unless you understand how pain is generated. So the first step really is to understand whether you have neuropathy, you have circulation problems, or spasticity, or restless leg syndrome, because the treatment can be quite different. For neuropathy, you will think about analgesics, you might think about anti-inflammatory treatments. For vascular insufficiency, there might be compression stockings, diuretics, skin care. Spasticity might call for antispasmodics. Sometimes you want to avoid systemic medications and give local Botox. Restless leg syndrome, again, you want to treat differently by thinking about dopamine agonists and other agents. So the attention to this detail is, I think, what will bring about progress. Not one size fits all, and pain is not of the same etiology and the same underlying cause in all patients. And sometimes there are multiple different pathways coinciding. So I hope this has helped patients understand how we think about pain and leg discomfort, and will also help empower them to seek out specialists that will address this from different directions. And I see that Dr. Wishart has also joined me. So thanks so much, Brian.
Well, thank you so much, Dr. Eichler. There has been not a surprise, there's been a flurry of questions coming in. And first question, so we've mentioned the 4 different types of sources of pain: neuropathy, vascular insufficiency, spasticity, and movement disorder. What kind of tests or how do you determine what is the cause of someone's pain, and what kind of doctor should people seek out in order to figure out where the pain is coming from? Is it neurology? Is it a pain specialist? Where should people go, and what tests will help make this easier for you to address?
Yeah, I think in general, it helps if you go to clinics where there are multiple specialists and people working together, whether it's neuromuscular specialists working with people in neurogenetics, such as myself, but importantly also physiatrists like Dr. Wishart, and finding those kinds of resources that help look at a problem from different angles, because often it is not just one thing that is causing pain. There might be multiple different things going on at the same time. Brian, you want to weigh in?
Yeah, I thank you for that talk. And I think there's a lot of stuff that you talked about that was really enlightening, and I think really speaks to exactly kind of that last part, that etiology is the key. And if we don't know exactly what's causing the pain, we're sort of just shooting in the dark. I do feel like it's been really helpful having the multidisciplinary approach, ALD in particular, and the myelopathy associated. is often multifactorial when we think about this pain. And there are a few different aspects, whether it's that restless leg component, there's a component of the proprioception, this piezo2 aspect, I think is really exciting potentially, that we might have a better insight into some of these aspects. But that sort of central sensitivity we see in other diseases is often really challenging, but it is treatable. And I think that when we've seen people have pain, go through treatment, and not be successful, it's often that we're not addressing all components, or we're addressing the wrong component. And so having kind of insight from a couple different sides and making sure that we're treating the appropriate thing is going to be the key part here. So it's usually a combination of tests, and there's probably not a single test that we could say this is what it is. But we get EMGs, nerve conduction studies. Often we've seen a lot of women go for MRIs and have musculoskeletal issues, but I do think there's a secondary component there, which is often this proprioceptive and probably this piezo2 aspect of things. And so I think that that's sort of the key, is being comprehensive and thoughtful as you go through.
Sure, thank you. With respect to neuropathy, one of the earlier questions that came in was a patient she said that she has terrible neuropathy and pain, and she walks with a walker. And we're just wondering what specifically can be done. Is there a procedure? Is there a medication? Is there something like, acupuncture, or are there other things that might come in and be able to be helpful?
Yeah, I can jump in. I think that when we think about the neuropathy and we hear that there's gait issues, again, it does take, I think, a pointed exam to figure out exactly what we're dealing with, whether it's radicular, because you can have issues that are coming from the back, shooting down, and that can be worsened by an abnormal gait that comes from that spastic gait pattern. There are certain medications when we think about the nerve pain that are very specific for that, such as our gabapentin or pregabalin. There's also other types of medications that we can move to. We've seen a few people go for different types of surgeries, particularly orthopedic surgeries, and I do see these patients as being the types of patients that come back in sort of that failed back type of surgery, where I've had back pain, this, that, and the other, and we have the surgery and it's still there. And I think that that's often because we're treating it as if it's solely a mechanical issue due to a disc or something, when the reality is that there are issues with our dorsal column, there are issues with our with the peripheral nerves, and if we're not thinking about those and addressing those, we're going to fail. And I do think the other part that was key to the question is that the gait abnormalities, right? If we're having significantly increased motion at our SI joint, at our lumbar spine, stabilizing and giving us more support to make sure that, one, we're safer, we're not having falls that are further injuring us and putting us at risk, and two, putting it into a more typical mechanical movements are going to be helpful as well. I don't know if I answered the question, to be honest.
For sure. For sure. And then, so a follow-up question, certainly, spoiler alert, I co-facilitate the monthly women's calls. And we've recently had many people mention that they've had surgeries, knee surgeries, replacements, etc., that not only were not successful in alleviating the pain, which kind of speaks to what you just said, but also they felt like their healing was delayed. Should people who know that they suffer from ALD or AMN, should they pause before they try to intervene in this way? Does the decreased, the vascular insufficiency, does that lead to delayed healing or, other therapeutic challenges?
Yeah, I think there's probably more that we don't know than we know. I think we're still sort of at the beginning of understanding a lot of these things. And I think particularly in women, we also hear a lot about, the process of wound healing and often many women going through multiple surgeries and injuries that they recover very slowly from. And how is that leading to altered nerve plasticity after the injury or after the surgery. These are still things we don't understand well. But I think it is safe to say that if you have a small fiber neuropathy and you have altered circulation in your legs, that your recovery process will be longer. By the same token, I think if you understand the components that are going into this, you can make amends and prep for these situations. And I think we really, as Dr. Wishart said, we need a multi-prong approach with multiple different specialties involved here. So we're working very closely with physical therapy, also pelvic floor physical therapy. We're trying to really come at this from different angles, because if mobility is impaired, if there's no good rehab program after any intervention, patients are not going to do as well. And so you have to really look at this in a holistic way. And I think that's an important message. I think that we're learning, and we're also trying to pass on to patients affected. I know, Kathleen, did that in part address questions?
Absolutely. That was the kind of the general consensus from folks, at least, patient experts, was that we felt like there was delayed healing, and there were situations where people had regretted getting kind of standard surgeries that people who don't treat ALD had suggested to fix. They gave a non-ALD answer to something that may be an ALD problem. And so they had followed those treatments and then regretted it perhaps afterwards because of the delayed healing and because it didn't actually address the symptoms they were having.
Yeah, the other side of that, I think too, because we've done this a couple of times with a few patients, is that it's not off the table, right? We're not saying like, if you have very classic symptoms and you need that knee surgery, that's it, that this is not an option. I would just be cautious going into it and recognize that it should not be the first line. We should be kind of going down those steps. And I would make sure that we're having conversations with people that know ALD and know that disease process and trying to put this all together to make sure that this is the appropriate place. And maybe it's our last step, right? Maybe we go through a couple of different options, and if we're still not there, then we go to that point. But I think it's been hard, honestly. And I agree with Dr. Eichler. There's a lot we don't know about this, and we have struggled with the pain for some women. And so the one thing that I think I missed from the other one is some of the complementary treatments and alternative therapies that might be options, such as like acupuncture. We don't use it much in our clinic. I don't think that's because it's not something that works. I think it's just something that has not been addressed at this point with us. In my kind of prior life, I had worked with a number of physicians that were acupuncturists as well, and it works fantastic for pain. It's probably one of the few things that has good literature. I think acupuncture probably works for a lot of different things, but pain is one of the ones that it really does show success for. There's a whole field called auricular or battlefield acupuncture, which is particular to the ear, and the military is using that in the combat in place of opioids when somebody's had a severe injury to help get them off the battlefield without slowing down their cognition and that sort. And so I've had a number of patients outside of the ALD world that have used that in different settings and been really successful. So I do think it's a wonderful option. There's a couple different ways of going about acupuncture. There are acupuncturists that are physicians as well. I think it's probably a good option if it's that complicated. I also think that there's classic Chinese or traditional Chinese medicine people that just do acupuncture that are fantastic and would be able to help with this as well. So worth trying. Just depends on what the symptoms are in particular.
And then in following up on that, in terms of kind of non-traditional treatments, there were several questions about marijuana and CBD. And I don't know if you guys have an opinion or can have an opinion about whether the effect, or even if it's anecdotal, of the effectiveness of that to treat people's symptoms.
I don't know if we can. I think we can. So there are a few specific diagnoses that you can get certified by a physician to say that you would be qualified for medical marijuana. Spasticity is one of them, intractable pain is one of them. And so I do think that there is a potential role for it. The reality is it's still a Schedule 1 medication, so we can't do true trials on this. And the literature and the research that's currently going on is not ideal. It's, we don't know exactly what type of combination between THC and CBD you're getting. We aren't the ones prescribing it. We're sending it to one of these, dispensaries, and the pharmacist there is giving you what they think is best. And they've also found that they're not necessarily consistent. So there's a couple different names for one. Charlotte's Web was one of the early ones. And I've had families that have actually stocked up on it because they've gotten one batch, it's worked really well. They've gone back, got that same exact type, and it hasn't worked quite as well. And it's probably because there's a different ratio between that THC and the CBD that's in there. And so when they found one that's worked, they've bought a bunch of it, which may not be the best strategy as well. So I do think that it has a lot of roles. I think that we're not in a place from a medical side to be able to say 100%, what's working, what's not working, how we would actually prescribe it appropriately. And so it ends up being a bit of trial and error.
Yeah, I think it's very hard to generalize some things here, right? And it's not because there is some hidden answer for all that we just don't understand right now. It's rather because our bodies are made up in different ways, and you need to go through that kind of careful examination. And just to be clear, this is also you relating your experience to us medical providers and providing that level of detail that helps us understand this, and going back and forth and trying different things, optimizing it, assessing every step along the way. That is what, in my experience with Dr. Wishart and others, has really led to improvement. It's not just using one medication that others have found beneficial, but it's really that understanding of the right dose, the right time of day, how to improve sleep, how to address many other aspects of daily quality of life, that in combination brings relief. I hope that came through.
Absolutely. And so you'd mentioned that that people have been trying, may have been experimenting with marijuana or THC or CBD to treat spasticity. There have been several questions about a baclofen pump, and one person, I can't say, Eric had mentioned that he had success and was wondering why this is not offered to all, or what would be the downsides of a baclofen pump. So I'm wondering if anyone can comment there.
Right.
I was thrilled to see the question. I personally love baclofen pumps. I can tell you one of the reasons is because it's a big undertaking. There's a lot that goes into it. You need to make sure that the system you're in has a good overall management plan. You need neurosurgery involved. You need somebody to manage the pump. You need emergency kind of backup. You need good front office that's going to make sure refills are getting done on the front end. And so there's a lot of work that goes into making sure that there's a pump program. I grew up in my training doing a lot of pumps for children with cerebral palsy and that sort of thing. It gets used in the MS world because it is very titratable. I think it's probably a good option. One thing that we have seen, I think that I've seen, and I've spoken with Dr. Fatimi down at KKI about, is that there's probably a little bit more weakness underlying our spasticity in ALD than we see classically in stroke and some of the other symptoms. And so that may be why I think in the question, it had mentioned a bit more fatigability in your legs after this, is that when we take away that tightness, by definition, there's weakness underlying that spasticity. And I think there's probably a bit more. And so for Botox, I've been doing lower doses in my patients with ALD because we've seen more weakness come through. And so I do think it's still a very good option because you can really be very specific and you're using micrograms versus milligrams. But it is a full surgery. It does mean coming back for refills. which is a needle through the skin into the pump, and it comes with its own risks. It just hasn't. I think the reality is that the reason it hasn't been looked at further is because it just hasn't been looked at further yet, and we've been sort of slow to get there. But I do think it's a good option. I'm glad to hear that it's probably helping.
Excellent. My follow-up question is, there was another question about substitutions when baclofen is not available. And I know you may not want to answer this here. If that is someone's situation, should they just reach out to an expert? Or I'm loath to read the whole question, although I know very well people can read it in the chat, only because I don't want people to try and self-help in other situations. So are there other treatments along those same lines that are available? And
yeah, for sure. There's a whole slew of anti-spasticity medications. Baclofen is often our first line. It's relatively low risk outside of a little bit of sedation. There's another large set of them, from Valium if you're really having spasms at night, to Xanadine or Xanaflex is similar to clonidine. It can be really helpful and often is used as one of the first line in spinal cord injury if that spasticity is more spinal related than central or cerebral related. Dantrolene is another one that's a peripherally acting one. It can increase your LFTs. I'm probably missing one or two in there as well. But yeah, there are absolutely other options out there. And so if you've had issues with baclofen, if you're having too much sedation, you're not having a good effect, the other side of this is thinking about if you've had an effect, but it's not lasting long enough. There's a bit of kind of pharmacokinetics that need to be talked through, whether an increased dose or a more frequent dose would make sense. So yeah, I think, having a good conversation with whoever's prescribing for you, or if they're not comfortable making changes there, seeing if they have an expert that can help with that.
Sure. And speaking of experts, if you're someone who that is not lucky enough to live near, say, a Mass General where you can have a multidisciplinary team, what are those patients to do? Do you recommend making a field trip and being seen by a whole team? Do you recommend getting your own local doctors to work alongside? Can you create your own team? This is a constant question because we know if we got a map out, we would find expertise pooled, but what happens in the rest of that space?
All of the above, right, Kathleen? So we always say, do what works, don't do what doesn't work, okay? So we might say this is the right way to do something, but if it's not appropriate for your setting, it's not appropriate. And so I think you want to really, keeping a journal of your symptoms, understanding what might be triggers, understanding details of what you do day to day, your amount of mobility or lack thereof, all of that detail contributes to a better understanding of your own body and thereby to better treatment options moving forward. We're always available by email to point to resources or to interact with local doctors. There are certain things that are hard to do remotely, and so we like to see patients in person because you can't assess sensation, you can't assess spasticity remotely. You need to have that hands-on exam. And Dr. Wishart and I spend a lot of time examining patients to really understand in detail what is happening. So there are limitations to remote assessments, but we're always glad to give advice to local providers and doctors. And I think you want to seek out physicians who are open-minded, who have your interests in mind, who have knowledge, but they also have some awareness of what they don't know, okay? And so that kind of awareness can help them partner with others and work together with others. And that's often, in my experience, what creates good care.
Sure, absolutely. I have another question that was sent to me that is privately, someone asking about swallowing difficulties, either with or without pain. How is that related, or is it related? Is this part of ALD? Is this not part of ALD? I just know these questions come up a lot.
Yeah.
Can that weakness be everywhere?
Yeah. So we are hearing more about swallowing difficulties and also voice changes over time, but it is too early for us to universally say this is all ALD. So I would say again, the devil's in the detail here. You need to undergo a careful exam. You need to understand, what your brain MRI shows. Assuming that there are no other causes found, it is quite plausible to think that this is related to ALD, but it's not something that we come across in every patient, and I would be hesitant to jump to the immediate conclusion that it is first ALD. I think when you go about these kinds of questions, you first have to rule out everything else, and that's what we do in order to make sure we're not missing something.
Sure, and I know we only have a few minutes left, but Luann has posted several very interesting questions, one of which was the piezo kind of breakthrough. Just thinking ahead, do you think that might lead to a medication that could help compensate or counteract for VLCFAs? If you do learn that the piezos are being disrupted by very long chain fatty acids in those cell membranes.
So we're looking to the broader field to get insights. I think the fact that in the past 10 years that there's been so much research on piezo makes me optimistic that we're going to see new targeted medications to that channel. Whether, and I want to be cautious here, we don't know whether the very long chain fatty acids themselves are altering piezo channels. A lot of this is still in the stages of early discovery and at this point theory. So I don't want to have people leave here thinking that we've figured this out, but it is very suggestive based on work that Patapudia and others have already done that the lipid composition of membranes does affect whether piezo channels are open or closed. Certainly, influencing piezo can be independent of the very long chain fatty acids, and so again, I think we're going to in the future look for a multi-pronged approach. Beyond lowering the lipids, are there ways of influencing some of these channels? So I think they're exciting days ahead.
Excellent. And then there's also been requests for, if it's possible, to share your slide deck and the articles that you've referenced. I certainly can hunt down the articles, and we can circulate in a ALD Connect news update at some point. But if we might be able to share, this recording will be shared and live for eternity on our YouTube channel and on our website. But there's been an additional request for your slide deck in case we can also circulate that as well.
Sure.
Excellent. Well, thank you so much. It's 2:55, which doesn't seem possible. This hour has flown by. I think we got to many or most of the questions, but knowing that, as always, we never have enough time to answer all our questions. I'm so grateful to both of you, Dr. Wishart, Dr. Eichler, for sharing your expertise on this really important topic that really, is unfortunately a visitor in almost all the ALD adult patients I know. So although it's not exclusive to adults, unfortunately. But thank you so much. And everyone who's watching, please take a few minutes. We're going to shut this down, and then we go back to the breakout sessions, remembering that there is one for men with AMN, one for women with ALD, a cerebral ALD group, a monitoring phase newborn screening, asymptomatic pediatric patients, and the Spanish call. I will also note there will be a Spanish translator available in the women's call for those who would specifically like to participate. Thanks very much.
Thanks for having us.
Thank you.
Thanks very much, guys.
Anybody who wants to email me can do that. Okay, good. Take care.